Friends, a very warm welcome to the last Empower Hour of 2021. And it gives me great pleasure to welcome to this Empower Hour my colleague, my friend. I admire her very much, like many of you sitting over here. That is none other than Captain Dr. Usha Banerjee. And I must admit that this entire thought process actually came from advocacy committee of Association of Nurse Executives India. How the patient safety focus came in. And can you hear? Can you all hear me? Okay. So patient safety focus came in because of the suggestion from advocacy committee, and then we took it from there and we converted that into Empower Hour, and that is going to stay with Annie for years to come. Please mute yourself. Don't force us to mute everyone in one go, and please stop your video also. Madam, please, you can mute people. Thank you. So Empower R is going to be there in 2022, again, focusing around patient safety. So a very warm welcome, Usha, to Empower Hour. So, so without much ado, let me just apprise everyone how this format is going to be. So it is going to be a little different from the other Empower Hour. No presentations here, and a lot of people who facilitated the Empower Hour is also in the group. So as we are having a chat around the topics of Empower Hour, please, if you have questions, please make sure that you put it in the chat box, and then we can, towards the end of our chit chat, we can take those questions. Right. Let me start with just a second. There seems to be some disturbance. Can we just ensure that everybody stays muted, please? Otherwise, we may be forced to, remove everyone. You, I am not able to get the speaker on the thing. There's one Vivo 1820 just getting fixed on the screen. Just give me 1 second, please. Ping somebody. Okay. So, Usha, let's start our chit chat. Hannah, may I request you to keep everyone muted? Otherwise, I'm going to mute all. Maybe that is a better option, I guess. So, Usha, let me start with my first question. So the first topic, January, of course, we introduced the Empower Hour with discussing that patient safety, we only address the tip of the iceberg. And I'm very sure all of us agree the kind of harm or the events that we document or we capture probably is not everything that will happen in a healthcare setup. So the second in February, we discussed about the need for patient safety to be educated through nursing students. So before they come, they are aware of it. So what is your opinion on that? You have been championing it forever, I know. So I'll pick your brain on that.
At the outset, greetings, namaskar, good morning, and thank you, Ms.Thankam, for meticulously hosting this Empower Hour month after month. And I also thank all the chapter heads and the members of the ANEI family for bringing this to the entire world. It's lovely to have a chit chat today and talk about something so important in our lives, which is all about patient safety. And we are wrapping up all that happened through this year. So at the outset, I would just like to put a preamble here and say that while this global uncertainty that has plunged our lives, everyone's lives and livelihoods into a still unfolding crisis, we must be proud that as ANEI, we came together and we made good progress. At the outset, I think I salute every single nurse and the other healthcare workers for having fought this battle bravely. And this battle would not have happened as a war and the kind of resilience we have brought in order to put the country back on the map. And I'm very, very proud of every single person who has contributed. And I must put on record the tremendous efforts that went in, even by the student nurses. And I know that the student nurses rose to the occasion. They did their best. But what is essential for us today, while we've made great progress in the last 1.5 decades on patient safety, we have leapfrogged, we have started to talk about patient safety in every single organization. I think it's important for us to do a backward integration and ensure that every single nurse in the first 3 months of her stepping into a nursing school or college, we must ensure that she focuses on the core processes. And I think we should list down that process today. Can every single student nurse do a 2 identifier before doing any intervention with the patient? Simple 2 identifier. Is it too complex to teach? Can we talk about hand hygiene? Every single student nurse in the first 3 years commits that she uses the 5 moments of hand hygiene and the various steps that are taught. Every single time that she administers a medication, she ensures that the process is followed. And I don't think anything has changed right from the time when we were students to what it is today. We have to talk about basics. The basics are not in place. Thankam, you and me know it. We deal with nurses every single day. We wake up every single day with some mistake because someone has deviated a process which we learned as young nurses. So today is time for us, while we talk about accreditations, benchmark practices, the whole quality structure, let us get back to our institutions. Let us go back to the students and teach them the very 10 basics, which we can probably define, which is all about critical information, identification, preparing up a patient for surgery or handling a medication or preventing errors which could be preventable. So for me, my experience is that in order to ensure that all nursing students know the basics of patient safety, each one is responsible. Each one of us is responsible. Each and every nurse today who's working in the hospital should get back to her institution and teach, at least take 1 session when you're on a vacation or visit your institution. And today, everything is possible on virtual network. Yes, Thankam.
Yes, I totally agree with you, and I 200% resonate with teaching the basics. I think not only for students, all nurses should be so thorough with the basics of patient safety. And I'm very sure next year we are going to do more work around this so that the basics and understanding of patient safety can be discussed still further. So, coming to March, we had being an effective team player in patient safety. So there we discussed about the importance of team dynamics in patient safety. So can you recollect any such event that could have happened because of poor team dynamics? Because I have experienced them myself, so I'm very sure you also must have seen what can fall through the cracks when the team is not gelled together. Can you
I think,
elaborate on that? Yeah.
yes, Thankam, this is actually a wonderful question. And we all know the very word team. Together, each one achieves more. And I think we have not yet fully leveraged the potential of the word itself called team. And we all know today, one single patient is dealt by multiple stakeholders. Every department has to come together to serve that one patient. And unfortunately, the reality is that we work in silos. We just don't integrate everyone together. We don't discuss the patient together. We do not monitor the progress of the patient together. We do not communicate enough to each other. We do not hand off to different teams. So, as a result, every single day, trust me, I know there are many administrators sitting here, there are many charge nurses, we wake up to an error because of a failure of the team dynamics. I can probably write a book today on the failure of team dynamics, and I think we can all co-author it and publish it and get great mileage out of it. I can quote numerous events where people have failed to play as an important member of the team. Let's start at the helm. When doctors round, they don't involve the rest of the stakeholders. The nurses are silent spectators. They don't talk enough to each other. They don't consult each other. As a result, even the nurse's notes, which is so elaborate, is not looked at while doctors are planning for care. So that's where it begins. It begins right there, that there is a failure of playing in across as a team. And then it cascades, even between nurses, you see that many nurses take care of one patient. Somewhere they don't play in together as a great team. And I think very, very critical. Just to list a few examples, let me tell you, we talk about surgical site marking. Surgical site marking, I know, is done by the doctor. But when a patient is out there and the patient reaches the operating room because the surgical site marking has not happened in the right manner, can we absolve ourselves of the responsibility? We together were a team. We played that safety net. So that's one big one. And you could have a wrong site, wrong procedure surgery. Consent. Look at litigations. When you look at litigations, you find that a consent was not completed. Every member in the team has a responsibility towards that consent, right? It's putting your organization, yourself, your medical practice, each one of us at stake when it comes to a litigation. Blood transfusion. The doctor nurse, the nurse herself has to go through a compatibility check. A failure of one person, a wrong blood transfusion to a wrong patient. Extravasations. Now you see, most of us deal with chemotherapy, and we know that there are chemoports available and there are many other methods of giving chemotherapy. But you generally notice that a patient is still on a peripheral line. Why? We're not talking together to the patient on the complications. And when a complication happens, it becomes a nurse's responsibility, right? So where is the team? A wrong sample, an incomplete sample, a wrong report is all to do with teams. And I can tell you many, many such examples. And when a young nurse comes in and asks a team leader to help her on a particular procedure, she doesn't. I've even witnessed a very fatal complication where someone in the team has not played their role. So I can give you many examples, Thankam.
Thank you, Usha. So the team dynamics are very important within nursing, within the organization, between doctors, nurses, and I think you have listed enough of examples to say that how the failure to be a team player can lead to patient harm. And I think that is something easily fixable. So we need to work towards that. I'm going to ask the audience, as you hear our dialogues, if you have some thoughts, please put them in the chat box. Towards the end, we will look at the chat box. And if you have questions, please post them in the chat box. That also we will take up after our dialogue over here. So thank you, Usha, for that answer. And now we are April and May actually concentrated on communication. And communication, we know that is the top three. It is always either remaining as the top one or two or three. That communication, whether it is lack of communication or miscommunication or no communication, is the root cause of many sentinel events across the world. India, we do not have enough data to prove, we don't have enough. Uh, so what do you think of that? Do you agree to that? And what has been your experience, communication being the fulcrum on which the entire healthcare revolves?
Thankam, I can carve it on stone and tell you that communication failure is one of the biggest reason for an adverse event, biggest reason. And communication failure is what is impeding progress. We could have reached further heights if we all understood the importance of communication, which in my opinion should be embedded in the very fabric of the profession. And I know there are multiple reasons why communication fail or why there are communication failures. We know the organization type, the positioning of nursing there, hierarchies, boundaries, role clarity. There are multiple things. But trust me, trust me, in the last 1.5 decades, we have proven enough and more times. We have worked together to improve the role of a nurse in the organization so that they can speak up. There are opportunities for them to be empowered enough to stand up and say no. But one has to learn the art of communicating. I don't think even the most difficult doctor, when he walks in and doesn't do a hand hygiene or crosses a boundary on something and you stop him, he will be more than happy that you are talking as an advocate for the patient. So, honestly, I think it's time for every single nurse to realize that communication is very important. It is very important for nursing leaders to start taking up the responsibility to sensitize people. We need to talk to our colleagues and collaborative teams to tell how important is communication. And I think we've come a long way in a no shame, fair, no blame kind of a culture where people are allowed to speak up. There are safety culture reports that happen in organizations. Patient feedbacks are taken. So I think it is important that we understand that speaking up on time, speaking up in the right manner, the art of saying no, being firm yet polite, and communicating what is important to our patients play a significant role. And we can prevent a lot of errors. And every organization must put up a great escalation matrix where reports go up on time. I know many times, a patient falls and the nurse doesn't even tell anybody. And later on, you realize that the patient has had a fracture or has had an internal bleed. I think we shouldn't be scared to communicate. We should not be scared to say the right thing at the right time. And I think there are enough examples in the world. And I think we should go back, integrate it to our student life, and make it an important aspect of our day-to-day work. Have I answered that okay for you?
Yeah, thank you, Usha. But I will have a subsequent, slightly tough question. When I am doing some sessions, because I'm a trainer, so when I do some trainings, I still get to hear that we are okay. This is I'm hearing from young nurses, and this is not referring to any particular organization on a general. What do you think is the role of a nurse leader to promote communication and the culture of speaking up, when something goes wrong? Do you think the nurse leader has got a crucial role to play to facilitate communication within the nurses and within the organization itself to lead to patient safety?
Absolutely, absolutely, no doubt about it. Every single nurse administrator has to, right from induction, tell the nurses that they are free to communicate. It should be an open door policy. People should not have fears to communicate. Yes, sometimes mistakes will be endorsed, but I'm sure not. I at least know that we haven't terminated any nurse just because she did something wrong. But then you can't keep deviating processes and causing harm. But it's equally important for the nurse to understand that even though you have an empowered culture in the organization, and I don't speak up for my own reason, then how can we hold the nursing head responsible or the organization responsible? And it is very important for every single nurse to understand that there is no Masiha who is going to come and emancipate them from all the shackles they are in today. It is self-empowerment. And I think the organization will stand for the right thing. And we've come a long way in creating this transparent culture where people are allowed to report errors, and then we look at system process improvement. So nurse leaders play an important role. Don't shoot the messenger, right? and create a culture and look at systems. But every single nurse should also know that I can't deviate a process and cause a harm, because harms could be fatal. So, Tangam, do I have a question for you?
Okay.
Yeah.
Okay.
So, what is that most common gap in our understanding of communication with patients and caregivers?
Okay. That was our topic in May. I will answer it very concise manner. That I think that we feel the communication or the education with patients and carers are happening because we have that in the protocol. It is there as one of the patient rights. And recently, I happened to be attendant for couple of events in our family as a receiver of care. And I must tell that though everything is there in paper and probably it is being trained also, but we do not involve patients and carers by communicating with them that what needs to be done. And also the gap is that when the patients and the family, they're not from healthcare background. So I have heard this many times from many healthcare workers. My God, if I was in there, what would have happened? Because we are very much aware what should happen, what should not happen. So we are on top of things. So the gap, what I feel is that many times nurses tell a lot of things to the patients and family without validating whether they have understood. There's a very simple tool that we all learn called a teach back, especially when patients are going home. You're telling them a lot of things. When you go home, do this, don't do that, don't do this, don't do that. And we know that retention is very poor for anyone. 40% is gone just in the first hour itself. So unless they repeat it back to us, it may not stick with that. So I would only request everyone sitting here that we should concentrate on this basic tool, though we know it is teach back. But is this being practiced? The only way to know is start asking the patient by somebody else, so that the nurse can be sensitized that you spend 10 minutes teaching the patient, but unfortunately they didn't remember. So in the November Empower Hour, there were some very classical case studies which were discussed as to failure to teach patients appropriately at the time of discharge can lead to patient harm. So I would rest there, and I'm now moving on to medication safety. Medication safety is probably one of the largest and most critical aspect of management for any nurse leader, and probably that is one of the procedure nurses are 100% involved, not anybody else. I mean, of course, the doctors are there from starting from prescription sourcing, etc. So it's always a concern. So can you elaborate and also give maybe couple of tips as to how can a nurse leader and nurses stay safe when they are managing medication safety? I know it's a very vast topic, but I'm sure that in a couple of minutes you can kind of summarize it for all of us.
Well, Tangam, this is a grave fact that every day we wake up in the morning and we realize that some patient has had a mild to moderate or even to a serious harm just because some nurses indulged in a medication process and it has resulted in an adverse drug reaction. And when you examine this, unfortunately, we notice that they have just not followed an SOP. Right? It's not that there is no system, there is no process, there is no organizational effort, not that we haven't taught them enough, but it's unfortunate that you have not done your identifiers, you've not carried the file if it's a file system or an online process. And a lot has come into play in terms of automation, technology, prescription approvals, indenting approvals, and God knows what. And let's go back a few years ago when we were all young nurses and we were administering medications. I didn't think we had so many support systems and we had a lot of patients to cover. And we knew patients' medications by heart. So I seriously have no understanding why so many errors happen on us every single day. I can't say that I have, in my few careers of working as an administrator, seen a single day without a medication error. And that's an honest confession. And it's very, very painful for me to understand when you follow simple 6 rights of medication, and a few more rights have been added in, and a good handoff between two nurses. Involve the patient. Many times the patient says, I didn't get the medication. I don't know what medication did I get. And the nurse has to play the most important role because that's primarily her job. Her half a day goes in only, a shift, half a day goes in managing medications. And how can we get it wrong when I can understand a process not being there for high alert medication, or there is no regimental conversations regarding placement of substances which could be misused or which cause serious harm. I think most of the organizations in India today have these processes in place. So I would hold every single nurse to that Florence Nightingale oath, which she took, where she says that she will not indulge in harm, and play it by every single patient every single day, not checking an expiry, not checking the strength, not checking the drug name, not matching it with the patient's identity, not giving the right patient the right drug. I think we should not get into this anymore. I think a lot has been spoken. I know medication errors happen across the world, but if we are sensible enough, we are cautious enough, we can prevent that harm. This is my take.
No, I totally agree with you that though medication error continues to be one of the highest cause of serious patient harm across the world, so we are no more safer than any other data that is being displayed. And I totally agree with you. I used to tell my nurses the protocols are created not to make you feel bad about it. It is to make you safe. When you are making patients safe, you are also going to be safe. And I 200% agree that if you go with that basic initial 5 rights, 6 rights, even that if you follow, you will not harm a patient. And the call out is to all the nurses sitting here. It is worthwhile to take that 1 second extra to make sure that we are giving the right medication to the right patient in the right dose and route. That basic 6 rights. If we go through it, and as I'm talking to you, I exactly remember the kind of mistakes I have made in my career. I still remember, that instead of Lasix 80 milligram, I gave 40 milligram. Instead of digoxin 0.125, I gave 0.25. And I realized it immediately. And I remember, so it can still happen. But any amount of double checking will always fall short, because once the harm is done to patient, it is very difficult to retrack and say, okay, I will put another button and it will be taken back. We cannot. So this is as everyone says, nurses are the last defense for patient. Anybody can do anything, and I think that's what you alluded in the earlier part of the discussion also. Consent not being taken, the surgical site not being marked. A diligent, a very aware nurse can stop those things and say, okay, this has not happened, so I'm not going to let this go any further. So that's why we call nurses as the last defense for patient safety. And I totally agree with you. Now, the next month we did talk about surgical safety, right? So here I am going to discuss a little bit about wrong surgery continue to happen. So I think we already discussed, Usha, in the beginning. You yourself told that being a team player, nurses being taking the responsibility of double checking. So I will kind of remember my own experience when WHO surgical safety was adopted early years. Okay, we did a lot of training and we did everything, and then one unfortunate event happened where a misidentification happened. So I decided to go inside the OT. I mean, I usually don't land up in OT, but that day I changed. I went in scrub, and me being who I am, if I get into scrubs and wear mask and cap, nobody will recognize me. So I was inconspicuous somewhere there in the OT, just going around trying to understand why things go wrong. So that day I realized this checklist actually has become a tick list. People are very happily ticking, but not necessarily, especially the timeout, the procedure was just a procedure just being ticked. And this is what I realized that could be happening. So the entire organization had to and I think those days Dr. Atul Gawande was invited by Apollo. I was also invited to listen to him because he's a great champion of checklist, and he talks about the same checklist. They are very good, but they can be very dangerous because it can put us into a false belief of safety because everything is being ticked over there, right? So I feel that this is very, very important, that we should continue to monitor despite having SOPs. I think that's what the continuous quality improvement is about, that we should not rest by saying that we have all SOPs in place. I'm very sure you had been there managing all this even after I left active administration. So I'll just ask a quick one to say that how do you continue to focus on this, ensuring eliminating wrong surgery to patient? How do you empower nurses, or how do you go about managing that particular domain? I gave my part. I'm just trying to get the current situation from you.
Yes, Tangam, I think you are right. Checklists have become tick lists, and I also say this very often. And we've made great progress. And this is one space I feel we have made some good traction, because you don't really get up in the morning and hear about a wrong patient on the table, or a wrong procedure being done. Uh, I'm glad, because this is a sentinel event. So I think nurses have played a significant role in managing that. So, or even for example, a sponge count. So this whole process of sign in, time out, sign out, where teams come across before anesthetizing the patient, the anesthetist calls out to the team, briefs the team, and I've seen this happen because we are really, really focused on this, and I'm glad it happens. We've stood there, monitored, and then the surgeon before the incision does make the team aware of what is expected, and the nurse before closure tells where she stands in. And I know that many times nurses have stood in and not allowed closure because their counts have not mattered. So that's great empowerment, and I'm glad to tell you these kind of stories, because I have goosebumps when I say this, because many times the nurses have stood in. And I also know that the operating room nurses go through a very good verification when a patient has just come in. So this is one space that I take great pride in, at least for my set of organizations. And I'm sure, I don't know if others feel the same, but I must warn people that this is one area where extreme caution needs to be exerted, because a sentinel event could arise if the patients are not going through the checklist process. I know it looks tedious, but I think it's good to go. And we can pick up good videos and share it and role model it, and there's tremendous ways. And once again, in every question that you ask me, I feel it's important to show this to the students. It should start there so that they know that they play an important role even before a patient is undergoing anesthesia.
Thank you, Usha. In my own career as an administrator, one of the things I really appreciated was my OT nurses. I'm not a OT nurse, but I could trust my nurses to let me know if there is any problem, and that was very, very important. And I learned that as a very my first month of being an administrator, I learned my OT nurses should be with me so that they can pick up the phone and tell if there is a problem. Like you said, that when the nurses do not allow the surgeon to close the wound if the sponge count is not correct, even if the surgeon is saying, I'm sure that there is nothing inside, let's go ahead. And so I have had, a couple of experiences where my OT nurses insisted, and to the level of irritation, there was some bad tempers flying around. So I had to step in and be there, and I had to tell the administrator as per protocol that the surgeon is not going to decide. Do you want to tell to close the wound, or should we just go around and looking for it. So finally, we insisted, and unfortunately, we found the gauze under the dustbin.
But that's good
Uh,
for the patient. Yeah.
yeah, so I think I hats off to OT nurses. I think almost all OT nurses in my own experience, they're very diligent, except that sometimes they might buckle under the so-called very big surgeon. That's where we step in and give them the courage and the support to say, okay, you must be who you are. I mean, don't deviate from that. And I think
But I think the surgeons also appreciate the fact that the nurse stood her ground. If not, it could have led to a litigation for him.
later,
So
yeah, that's
yes,
true.
so that's the progress. And number two, I think OT works as a great team. So we spoke about team. You find more camaraderie and the teamwork in an operating room, unlike an inpatient setting. So that's yet another success story where teams come into play.
That's true. That's true. I think OT is one place. If the team dynamics are bad, then it can really harm the patient. The day
Disaster.
will not close without one
Yes.
event at least. I
Yes.
totally
Yes.
agree with you. I totally agree
Yes.
with you. And I'm sure that the OT head nurses, who, if at all any is here, they will be nodding their head 100 times saying that if I don't get my team together, I'm in trouble, because this is really a very high chances of errors, inside that OT. That is really right.
A
So
lot
coming,
rides on their shoulders. Yes.
yes, that is true. That's true. So now there are a lot of discussions has been around the human factors. You alluded to some of the principles of human factors in the earlier part of the conversation, where you said that no name, no shame, no blame culture. Where we kind of respect the human factors that could be involved. So can you enlist that? Why is it important now for all nurse leaders and maybe the mid-level nurse leaders to be aware of these human factors, and how can we drive that awareness?
Well, I think every single nurse leader must understand that today to sit in an administrative role on a chair so important, dealing with number of people of different age groups, different competencies, and the challenges of a workforce today that we are faced with attrition, new nurses, older nurses. I think studying organizational behavior, human resource management, industrial relationships, labor laws is very, very important for us. Today is an era of social media. The reach and publicity for good and bad is huge. And today we all know there is no point in blaming someone. Let's together work to improve systems, processes, focus our energies on developing competence, and stop lamenting about this whole hierarchy and bureaucracy, red tapeism, and the pyramid structure that we were following. It has to be a lean, mean, flat machine where everyone has to play their bit to achieve the goal. Everyone has to bat. Everyone has to play the game together to win. And I think sooner we realize and the faster we realize, it's good for us. Let people speak. Let there be debates. Let there be dialogues. Let there be a culture where there is transparency. Let us not, it's a new world, it's a new era, and it's a digital world. Let's maximize the use of all support systems to generate results that we desire. And I feel these human factors remain woven into the fabric of the safety management. I've said this many times. It's so hard for me to probably manage one single child at home, but I efficiently manage the nurses, and I'm glad my nurses listen to me. They're not here to rebel and create problems. They come to work every single day, and I thank them for that. I think the day the leader realizes that and gives them opportunities to develop, succeed, grow, progress, I think the nation is in the right place. And today, I have seen this last 1.5 decades, uh, you know, very good nurse leaders have emerged who are knowledgeable, who are tech savvy, who understand benchmarks. I think most of them are sitting on this table here today, who have reached into the corporate C suites. make decisions, have become an integral part of decision making in the organization. So, both for the nurses and the nurse leaders, I think it's a great time for us to understand that these human factors have an important role. And we all know these human factors have been understood very well in the aviation industry, whether it is a checklist, tick list, whatever we spoke about. I think they do it so well. And I think for us to understand that there are few clues for managing the human factors, I think it's for us to deal with ambiguity, information from two or more sources that don't agree. It's good to debate. I don't think we agree on everything that we speak, but ultimately, I think we decide on what's good. Similarly, being fixated, focusing on any one thing to exclude everything else is not right. Confusion, there'll be a lot of uncertainties and confusion about a particular situation. And there is anxiety and psychological discomfort. We must allay that. The failure to focus, we are focused on the non core areas. So that also leads to a lot of issues. The failure to look outside, these are all important human factors in, according to me. Failure to meet an expected checkpoint or on a plan or a profile. Failure to adhere to standard operating procedures. Failure to comply with limitations, minimums, regulations. Failure to resolve discrepancies, conflicts among people. Failure to communicate fully and effectively, and the failure to play as a team. These could lead to significant issues in an organization. I think if we plug those, we bridge those, we would have dealt with human factors. We must understand that different generations make an organization and everybody has a different story to tell. If we can bring everybody together and leverage the talent and this and the competencies of these people at different stages, I think we are good to go.
Sorry, I was muted. Thanks, Usha, for that elaborate answer. Human factors, I will try to make it very, very basic to say in my own experience. One is that our failure to listen to our team. That's one of the common reason for the human factors actually failing. And when something happens, the question, rather than who did it, asking that how can we stop this from happening again. See, who did it is just for us to know that why that person, there will be a dialogue with the person. So I'm very happy to announce today to everyone here that in the next 2022 Empower Hour, we are going to break down the WHO patient safety curriculum throughout the year through the Empower Hour. So we have patient safety fellows who are working with Patient Safety Movement Foundation. So those fellows are going to chip in and do every month one chapter, make it very simple, and then it will be available to all nurses and nursing students. So that's something that we are going to focus. Yeah. So let's move on. Let's also try to understand a couple of more things before we open the forum. I'm aware of it is 11:46. So I'm going to club a couple of questions together and then you can answer and then we can open the room for everyone
I
else
think
to.
Tangam, we will flip the question and now you take on the answers. So how do we actually learn from reporting and learn from errors? How do we, why do we fail to learn from these errors? What's the role of a nurse in clinical safety? So you take it on.
Okay. All right. I think clinical safety, it was dealt in October, and in September, we talked about reporting and learning from errors. One of the things that we, for time immemorial, everyone says that it is okay to fail, but it is a crime not to learn from that failure, right? So I think somewhere we also as nurses, maybe within the department, maybe many organizations focus not just the quality department trying to do RC and telling us this is what it is. I think as nurses we ourselves should be able to deep dive to understand what could have been done to protect this staff from making the error again. And I know that nurses do have their personal responsibility of preventing error, but discussing about the error itself. So when you read about an error elsewhere, what do? I will say, oh my God, I need to check my process. Maybe I have something that is, there is a risk sitting in my own department. So maybe I need to look into that. And when I was an head nurse in Middle East, this is what we used to do, that all the, ICU heads used to share what went wrong in their departments, and we used to tell each other that this is something happened. Maybe there is a process and something happened with narcotic. It's a very big problem in Middle East. So when one unit faces, immediately the call will go to others that you better check your process. I think there is a loophole. So then we come together and we kind of plug that loophole. I think that culture is what I would be, championing, to say, let us all come together and try to discuss, from our own experience. It is not very important to know which hospital, which nurse, when, how. No, the event itself. And I think that's how the case studies thing came into last month, about discussing about real case studies, how, what went wrong with the patient, and how that could have been prevented. So that is, uh, that's one way of learning from errors, is that documenting the errors and involving the team, especially the nurses who are part of that particular event. They should be invited to participate, to find what could be the solution. Many times I feel that maybe the nurse leaders are alone sitting in rooms. I'm not talking about any particular organization. I'm sure that many evolved organization, they have the right process in place, where even the young nurses are invited to discuss about the error that happened, and asking them how we could have stopped this from happening, and maybe we will hear more workable solutions so that this will not happen again. I mean, that is my take on the clinical safety. And I would also say that Annie is also one of our chapters, along with the education committee. I mean, those who are members, you will be hearing about it in the general body meeting. Another plan around collecting case studies next year, so that it is available to more people. I mean, without any name of the patient or hospital, so we can learn from our own mistakes, and we can prevent them from happening in our own organizations. So that is where it is. So shall we open the floor for others to discuss? I think I'm going to look at some comments we had. So I'm going to read them. 1 second. Identification errors is becoming very common. Oh, totally agree with Usha. That is Josephine. Genuine verification of high risk medication. So I think we all are on the same page when we talk about the high risk areas for nurses. You already mentioned about identification of patient for various, occasions, whether it is medication or procedure, and high risk medications. Medication itself is the same. Now Sandhya is talking about, well said, ma'am Usha, on nurses not to cause harm. But how do the nurse leaders drive it in the culture of their hospitals when nursing does not, where nursing does not work in silos? So maybe Sandhya, you would like to elaborate on that question. It's not very clear to me. What is that question?
So, yes, ma'am, thank you very much. What I mean to say is, when we spoke, and it was amazing to listen to the reflections. We talk about the nurses not to cause harm. We did speak about the small things, be it not identifying the patient, or not verifying the dosage, or breaching the processes. Nurses are not the only one. Now, while we extend care to the patients, there are doctors, there are pharmacists, there are physiotherapists, there are dietitians. She being at times at the lead, at times being missed out being the lead. But it is a very important and very most important challenge the nurse leaders encounter as on today, on how to drive this, that the intent is cascaded throughout the team, and everybody is converging towards causing no harm to the patients. Be it the doctor does not bother to, or has missed out on checking the criteria for shifting a patient from ICU to ward. The nurse over there struggles to monitor the patient at times while running from room to room, and the patient gets critical and comes back again to the ICU after some time. Now, be it the physiotherapist, be it the pharmacist, everybody who has attended the patient had seen the patient sick. It's only cannot be a nurse's call. What I mean to say is the nursing heads deal with similar this type of challenges every day and quite frequently in the during the while working in the hospitals. How does the nurse leaders cascade this intent to the entire team, converging them towards causing no harm to the patient? Somehow I would like to shift everybody's focus from being nurse centric patient care to actually putting patient in the center. Yes, nurse can be the on the forefront, and solution to this is act, nurses taking charge now on everything and communicating better, not only with the doctors, equipping ourselves with the vocabulary and knowledge to communicate with the pharmacists, with the dietitians, with the physiotherapists and the doctors. Meaningful conversation, that is again comes with the power of communication, which we should include in multidisciplinary team interactions in the upcoming empower hours or in the series, which is actually a need as on today. But this is one challenge I see day in and day out, which we are not able to do make much a difference on negotiation by the nurse leader in communicating effectively to her team as well as the other team caregiving team, members of the caregiving team, to ensure that patient goes harmless out of the from the hospital, be it impending dehydration, be it impending malnutrition. If people don't recognize, the assessments don't take place, and they don't fall into each other's communication handovers, so this area remains a lacuna, and patient will get treated but will go with the impending threats and harms back to home. So this is one thing, ma'am, which I wanted to make a statement as.
Okay, so I think what you're sharing is the need for a multidisciplinary approach and also not holding nurses solely responsible for everything that goes wrong. And I think that is where the culture is going to be developed. I'm very sure in India, definitely it is a challenge. And while I'm talking to you, I am thinking that as Annie, how can we start to break some silos? I'm having some idea, but we will see what best can be done. What are your thoughts on that, Usha?
Well, I think Sandhya has raised a pertinent point. I agree, nurse alone is not the person responsible for safety, or we can't hold it up against just a nurse. It has to be an organizational culture. And we did mention that in our talk. And I also understand that there are challenges to drive home this integration of a multidisciplinary approach to patient harm. And a lot, when events happen, I think a lot of questions are asked to the nurses and a lot of eyebrows get raised. Nevertheless, I have this obsessive optimism because I have seen this evolution of a revolution. I think most of the nursing heads, by virtue of an NABH or by virtue of what's happening in the country, are pitched prominently in the quality steering committee, right? Uh, when you have a position, you have a role to play. I think you should bring knowledge to the table. You must speak up. And I think everybody listens. This is my experience. So I honestly feel it is within our fraternity, within our community, to make that headway into managing the communication and the process adherence. Now, she took an example of a doctor. I think nurses are free to talk to doctors. If they don't listen, they can raise up incidents. The incidents go to the top. This is my experience. I don't say it's all hunky-dory and it is absolutely foolproofed situation. But I think that's the way a country moves. And I stare at a very good process in place if we all join hands together and take it upon ourselves that we will create a culture where every nurse partners with the doctors. I think most of the doctors look up at us to get that advice too. I think the medical heads also look up at us for that dissemination and participation. So let's do it that way.
Thank you, Usha. So, in summary, what I'm hearing is that one, the nurse leader herself needs to be knowledgeable and they have to bring knowledge and data to the table. And also, we should be willing to involve others. So, a little example when I was in Fortis was it's a very easy way to get others into the. So, if I need something in nursing, something went wrong in nursing, I will call all the remotest department to that meeting. I will say that I need your help to improve something that we are doing to the patient. So can you join us for a collaborative meeting? And I don't think anybody said no. And when we invite doctors also, sometimes they say I'm too busy, I'm this. So if I tell him, "Ki, sir, this is for your patient's care to get better so that we don't do it next time," then he will definitely, at least if not join, he'll say, "Tankam, I need 1, 2, 3, 4." So he has given his inputs. So I think so there is a lot of so all these things are now coming together. This is also human factor, how a nurse leader is managing the other team around them. So primarily it is not one person. Nurse leader has a lot riding on their shoulders. As long as they are aware that they are working in a multidisciplinary environment and they are able to reach out to others or even allow others to join with them to find solutions in the larger cause of patient safety, I'm sure that we will be moving forward. And he definitely is going to think about that, Santhya, for sure. So we have another question here, which
I think Miss Jyoti Clara raised her hand.
yeah, I'm just Jyoti, I'll just come to you in a minute. I'll just take one question, which is in the chat box. Once I finish that, then we are done. Nurses' individual factors are contributing close to 46% of non-compliance related to medication administration process. So that is hardcore data that is coming from Harita. So what are your recommendations on preventive strategies? So I think Usha already made that statement that nurses cannot be absolved about their role in ensuring safety to the patient. So are there any strategies that either Usha can suggest or anybody else in the team can, definitely unmute? I'll go with Usha first and then maybe I'll go to Jyoti after that. And if any other hand is there, we can definitely hear from you also. What are the strategies to ensure that the individual component of each nurse in medication error or medication harm can be reduced?
I think Harita has brought about a very valid point, and I already mentioned that you might have robust governance, great systems, you will have advanced technology to prevent errors. But if I, as a nurse, does not understand that I have to follow these steps and I deviate, I mean, I know this very often it happens. I'm busy and I say, Tangam, just go and give this medicine to that bed number. And that's the beginning. How can I put a strategy? I can only tell nurses, I can create communication channels, I can give them a great culture, I can listen to them, we can look at every system process, we can talk to other departments. But I think every nurse has to understand that she's a licensed practitioner, right? She owes this to her practice. She has to follow the SOP if there is an SOP. And I said this and I say this and I will repeat saying this probably till I retire, that if you follow the basic, simple 6 rights of medication, which was created ages ago, right from Florence Nightingale times, probably, we would not deal with medication errors. Trust me, at least the major medication errors would be prevented. Second is to involve the patient, show the patient what you're giving, tell him what you're giving so that he can say, yes, no, this doesn't suit me. We don't involve the patient. Third, I think we should create a national movement around medication. I think maybe we, as ANEI, join hands, reach out to students. So this is my thinking, because I still hold every single nurse responsible to her practice. So awareness, competency check, culture, communication, and each one making our own efforts and promise that we will actually do no harm should be the strategy for me.
Jyoti, would you like to come in?
Yeah, first of all, I'm really enjoying the day. Great leaders on screen talking about patient safety. And I think most of the participants here would have got a lot of ideas now what to do for 2022. In fact, I was also listening through and putting down some points and reflecting. In fact, I think this is a very good methodology that ANEI has adopted. Coming to the point Sandhya has told about communication. See, doctors wanted nurses to raise up. They don't want them to just follow their orders. That is what I am seeing in current days consultants' habit. And they were very open when they come forward to say, this is what is not right and you have to change it, because ultimately they are ending up with legal suit. So nurses are protecting them from the beginning. So they are very happy. Yesterday, I got a WhatsApp from one of my neuro intensivists, and he just took a photo of a patient medication administration record. And he said, I was so surprised. Nurses are writing there in the corner, action of each of the drug closer to the drug. And this is amazing, beautiful initiative. Thank you so much. This has come from this unit. And after this, we are seeing the errors are lesser. There was a major error that happened in the institution where nurses pointed out. They immediately attended to the patient, took the patient to theater, corrected it. The doctor came back and told, thank God this was escalated. We were able to save the patient. 5 days package, patient gone home on 5th day. If the nurse wouldn't have escalated, it would have actually got escalated by itself. The patient deteriorated, then we should have done something for the patient. Patient would have stayed more days, and then it would have been an additional cost for patient. So they started realizing. So what we have focused in our organization, I can only talk about this. I'm sure all of you are doing this as well. We shifted our mind to what went wrong to what went right. Second thing is simple task. The nursing leaders do not call nurses at the beginning of the shift and ask them, what did you do wrong, and corrections. Never put them under stress. Let them have a peaceful entry into work and let them plan the work, let them continue. Every hour leadership rounding, very important. Leadership, doctors only don't give orders. The nursing in charges give orders. They have to check each chart and say, oh, you have done this. These are the things follow. They can write it down as an order and the nurses can tick it. So these are some of the things if you break the tradition. See Sandhya, Usha and all other participants here. Who likes monotony? Everybody comes in the morning, gives medication, take care of the patient, go home. We have to engage nurses differently. So every day something should be inspiring them. So we have to have like shift hurdle in the beginning. Give them some thought process. If we shift our thing to, I have to be careful too, my patient should be careful. For me, patient is more important than my nursing director, than my doctor. There comes their boldness. So they can very, very easily come and give occurrences, raise occurrences, tell the points. So I think we have to also become more, member who thinks out of box, how to engage our nurses, break monotony, and shift their focus from my nursing director will call me to only scold me or correct me. No, if a nursing director calls, they should think, oh, something good I have done for the shift. So she's just calling me to praise me. So this is what I am aiming to do, because this shift will certainly make a difference in them. That will give them empowerment. I just thought out of box. If we try all these, I think Harita has been with us on best catches. Best catches have come out very well, because they are thinking it's easy to catch mistakes than to admit mistakes. So they come forward for best catches, and each best catch getting reward. CEOs going there and giving them a certificate. Oh, wonderful best catch. So we go and visit them at the nurses station and giving them just a card, thank you card, because they have caught a best catch. And whoever they have done, the clinical doctor, they give. That makes a difference. So these are some of the small, simple things. If we adhere, probably we can engage nurses and make differences in day-to-day practice to breaking monotony.
Thank you, Jyoti. I think we are really running short of time. We have to step into the next Zoom meeting, and all the ANEI members who are here, you are invited to join our general body meeting at 12:15 or just in another 2-3 minutes time. You can start logging in, but please make sure that your name and your chapter name is displayed, so that we can identify you as the ANEI member. So that general body meeting is open only to ANEI members. So thank you everyone for joining us on this Empower Hour, the last of 2021. And thank you, Usha, for wrapping it up so aptly around all the topics that we have discussed in 2021. And we will definitely meet in 2022 again, and wishing you all a wonderful, grateful 2021. Usha had told all the good things that nurses have done in this year, and big kudos to the entire nursing fraternity in our country. And thank you once again, Usha, and look forward to seeing all of you in 2022, the last Saturday for a new series of Empower Hour. And I think we have got some new work to do, because some ideas have come in from the team here. Thank you very much. And Usha, your last word, and then I close this meeting. Thank you.
Tangam, and of course, Sandhya, Clara, Harita, and all the nursing leaders and the nurses who've listened to us. 2020 was the year of the nurse, and I think it is just the beginning. It is going to become the era of the nurse. I think we have to come forward and revolutionize nursing profession by knowledge, competence, talent. And as I always say, this is my favorite, and I would say it every single time, that every single nurse has to be clinically competent. She has to be socially sensitive. She has to be ethically engaged. She has to have a quest for quality. She must strive for safety. She should be a lifelong learner. She must have an obsessive optimism and a persuasive passion. And she must work without fear or favor. Only then we will be able to hang our boots. We've set a trend. It is for every single person to join hands and make it better. I'm so glad I belong to an era where I have colleagues who have made Indian healthcare very proud with their leadership, and I belong to that community. So good luck to all the nurses. May our lives and our livelihoods belong to this country, which we will feel extremely proud of, and we will leave a legacy behind, because it's our nation, our healthcare, our patients, and our profession. Thank you.
I'm into that, and take care, and we'll see you next month and next year. And all the members, see you in our general body meeting. Bye bye.